Thank you, Francis, for the work that you do with the parents and for sharing your story with us. It's certainly a picture that we need to keep in mind every day when we deal with our patients. I'm not going to talk too much about myself. When I look at the room, I think I know most of you, and we have done previous work, and so I'm hoping that that work will come along, and we'll use that knowledge that we accumulated in the past from other experiences, particularly with HIV. Let me make a bit of a disclaimer. Although we are talking about how we build the HIV collaborative and how we can translate some of these learnings into the managing this crisis, and particularly the opioid use disorders, there are clearly differences, and we really need to think about those differences. While someone who is on an antiretroviral therapy requires treatment for many reasons, but for personal reasons, if they stop therapy, nothing may happen in the next 2 or 3 days or weeks or months. Well, somebody who is actually taking an opioid agonist therapy, whether it's methadone, Suboxone, or slow-release oral morphine, we know what happened. So we know that they will go in withdrawals within hours after their last doses. We know that they will go and try to seek something to overcome those withdrawal symptoms, and likely is going to go and buy something back in the back alleys or in the streets, which they don't really know what it is. And they might inject, and they may overdose, and they may die within hours. So this is why the importance of creating this kind of movement that we're trying to create today, by saying people who stop their therapy on the context of opioid use disorders is unacceptable. So that we need to help them. Of course, that needs to be done, as we did with HIV, in the context of the individual decision. So we're not forcing anyone to therapy that they may not want or they may not be prepared to take. But what we're saying is we need to keep these individuals engaged into our care and eventually start therapies that may be available to them, which are not necessarily only opioid agonist therapies, maybe other psychosocial therapies, withdrawal management, and so on. So just to set that stage, so we're very well aware of the differences. So let's not get trapped into this will be a cookie cutter, because it's not. There are key elements that we can actually use, and that's what we're trying to do today. So I'm going to give you a quick outline. So talking about a little bit about background, you're very well knowledgeable, you're in the front line, you know what's going on. A little bit about emphasis on quality improvement, what is and what is not. I'll talk a little bit about what are we trying to accomplish, and I'll give you a summary and leave you with some thoughts. One of the things that I did is look at the continuum of care, and you could actually look at this continuum of care not only in the HIV context, but think about other conditions where are chronic diseases such as diabetes or mental health illnesses such as psychosis, and you'll find that an awful lot of people remain undiagnosed, and they're undiagnosed for an unacceptable long period of time, and they might not necessarily benefit from the therapies. That had happened with HIV, and this is how we learned from HIV what we needed to change. Some people may be aware of their diagnosis, they may be receiving some type of care, so they may be going to a mental health team and receiving their mental health care, but not necessarily the substance use disorders care that they need. Sometimes people go to acute care and they're dealing with their acute illness, and they're sent back to the community with the hope that they will be follow-up. And then the fact that a lot of our clients also experience many other barriers, including those psychosocial barriers that Mary was talking initially, that we as clinicians in the front line may not have a direct impact in the system trying to change. So talking about poverty, homelessness, it's difficult for a clinician in the front line to address that issue. So we need a system change, and we need to approach it, and I'll talk a little bit about that, how we approach it from HIV and how we may approach it from the substance use disorder point of view. To your right side, which is the fully engaged in care, this is where we would like to go. This is where we really need to keep our clients, whether they're on treatment or not, which is the ideal scenario, but at least engage in some degree of care, so we can continue offering the options that they may be available to them. So that continuum of care is not linear, as we know. People come in and out of this. They may be fully engaged, but something may happen in their lives. There's a relapse, there's an accident, they need to get back into some medication, put them at risk, and there you go. This is why substance use disorders also need to be seen in the context of a chronic condition. And this is how we look at HIV. So when we discover, and Julio and his group and discovered in the early clinical trials, the effective therapies, that changed that kind of initial view of HIV and became a chronic condition. So we need to move into that idea, how we currently manage substance use disorders. I also wanted to make another disclaimer that I forgot at the beginning. I'm not a substance use specialist, an addiction specialist. In fact, I do have a methadone license. I have treated people with methadone in the past. But what I'm trying to bring here today is the system perspective and how we could influence the system to actually provide that better care. And you are the experts. Many of the clinicians have treated and managed addictions, and you're supporting those clients, and so you are the experts. So moving from the continuum of care, back in 2007, a group from the US move into looking at what we call now cascade of care. So how we translate that continuum of care into a measurement tool that can help us to inform where are we at a population level, but you could also think about also at an individual level. And so this is how we move into also generating the provincial cascade of care that tell us where are we at a provincial level. I'll come back later on but for now, just to say that this may not be perfect data. You may be questioning about, I don't think that's that many patients that exist. And you may be right, but this is a tool that gives us a state where we are and where we could go with this. And if we use it over time, we can actually see if we are making any progress. So let me switch to quality improvement. And some of you have heard me in the past talking about quality improvement, and I always emphasize this. Quality improvement is a journey of small steps. So it's not a rush. We need to be nimble enough to focus in our own practice. You as a clinician, as a team, as a practice. So what are the small steps that you can take that can lead us to this big picture that we are trying to share with you? I already referred to data. And it's important to emphasize that the data doesn't need to be perfect. It only needs to be good enough to understand that there are gaps and that we can actually do something about changing that. So I'm not going to use a lot of data today. I usually use a lot of data because I'm sure you know a lot about this, but I'm only going to give you a few flavor of why I went back to Julio and to Laura Case in Vancouver community and Mary to say we need to do something about it. This is unacceptable. So Dr. Kerry Pendle through the public health office, through his public health office, issues this report. And this is the most recent report. Actually, it was released in February. And it talks about data from performance measures for the province from 2014 to 2016. And those are fiscal years. So I was very impressed when I started flipping through these pages, and it clicked to me that this is exactly what we saw with HIV. So we had knowledge, we have therapies that are proven to be effective, not 100%, but for those who actually use it, is benefit. So we have the science. And then we have these metrics that are saying that not everybody is benefiting from this. And there may be many reasons. And this is not a judgment, but there may be many reasons, and we may not even understand it clearly. But certainly this could actually help us to make those changes. I'm only going to show you a few things. So we know that for a patient, and this is not me, I mean, the experts will tell you later on, but we know that there is a minimal optimal doses of methadone for people to benefit in terms of oral substitution. Usually it's set around 60 milligrams. The literature it moves a little bit from one place to another, but more than 60 milligrams is pretty safe to say. And then if you look at this data from Dr. per Kendall, it shows that it's less than 55% of our clients that were treated in our health authority, here depicted in green, are the ones who are achieving that minimal dosage. So how can we, it's like giving substandard half of the therapy to manage hypertension, or half of the insulin to manage diabetes. So that's unacceptable. So if we're putting someone into treatment, we need to ensure that these individuals reach the optimal doses. The sooner the better. And I know there are many barriers, and this is what we're trying to change. So what are those barriers? You know them because you are dealing with them every day. How we reflect back into this as a system. How we, our CEO, our chief operating officers, your directors, the medical directors understand this to support you better, to change that picture. The next point that I want to do is just look at retention. Methadone, initiating methadone or Suboxone is not enough. The people need to stay long enough in these therapies to actually benefit from them. And you know that, but you may also be surprised that when you look at retention at 6 months, and this is not my data, this is provincial data coming mostly from Pharmacare, shows that at 6 months is only about 39% retention. So we start people, only just roughly 1/3 of them actually stay on treatment for the first 6 months. And this is even worse when you look at the 12 months. Actually, it drops less than 30%. So here in green, BCH, 29%. And they did not include only our clients, it's all the clients registered in BCH. But we have a good sense of who they are. You know, mostly are our clients, and they're very complex, and they may be different than clients that are going to some more other places. But you should have seen the reaction of my CEO when she saw this, Mary Houston, when she saw this. First of all, look at BCH. It's at the lower end of all these charts. So, there's not, the point I'm trying to make here, we could dive into this data. There is way more information in the reports. This is why I put it up. You're free to go back and understand the limitations. This is not a discovery right now about who they are, or where they are. This is just to say we're doing worse than others, and there may be good reasons why. You have the more complex populations. We might have concentrations of people who have more mental health disorders or concurrent disorders and so on. We can explain it, we can find a way. But you would agree with me that it's unacceptably low, and we got to do something about this. And exploring the data is not just the thing that we need to do. We'll leave it that for the scientists and Julio and others at the BC Center on Substance Use, and some of you who may have also interest in the science piece. But from a QI, from an outcome perspective, this is unacceptable, and we got to do something about it. And yet we know that retention in methadone and Suboxone is associated with substantial reductions in the rate of all-cause and overdose mortality. And this is one of the most recent systematic reviews, which actually was published recently. I'm not going to go in detail, but it's just to say things you know. I'm just reaffirming. We have a large proportion of people who are not benefiting from that intervention, and we know that that intervention is actually effective in preventing death. So this is what I call science. So this is part of the science. We know that. So we need to bring that science into practice. So what are the things that we need to do? And I'm not going to span a lot on the clinical side because my colleagues here, one of my colleagues will talk about that. But just suffice to say that VCH about 2 years ago launched the first systematic guidelines, clinical guidelines for the management of opioid substance use disorders. And that merged more recently onto the guidelines issued by the BC Center on Substance Use. So the science is there, you can review it, it's being vetted, it's being qualified in terms of the strength of the evidence and so on. So it's right there. And we know that it's a spectrum of treatment, and there is an intensity of treatment that starts from that withdrawal management to offering agonist therapies to eventually even increasing the type of medication that we could use to eventually including injectables, right? So it's a spectrum there that we need to examine. All needs to be supported by harm reduction all along this process. And mainly because, as I suggested, some individuals might not be ready to engage in any therapy but harm reduction. So this is not about one idea versus the other. This is about applying what we know. So for so long, I've been talking about the chronic disease, and that's how I framed the issue when I went to talk to Julio the first time about the changes that we needed to do at the HIV clinic at St. Paul's, with this notion that there is medication, makes people's life better if taken and if adhered to. So the similar issue we're talking about here. The reason I'm bringing the expanded chronic care model is just to emphasize the point that the only thing we have direct control over is the health system. It's how we deliver services. We cannot control poverty. We cannot control homelessness. But we certainly can partner with agencies or organizations that do that. And that's the concept of now, after we focus in the health system and optimize what we can do, how we shift in the community. And the whole idea here is to move from where we are today, and not all of you, but where the system at large is being very reactive. So what we do is, as I reflected back in that patient who was on methadone, who stops, who goes into withdrawals and gets something, is that the patient stopped that medication. We may or may not receive information that they actually stopped the medication, or that they didn't show to their appointment. But they will inevitably come back to us, and most of the time come back to us after an overdose or after being in hospital, and that's when we realize, oh, this patient has been off therapy for this long. We got to change that. We need to move from that reactive system to a proactive system. We need to anticipate. We need to know who are our clients, who is not showing up today. A particular client may require their medication at 10 a.m., which usually, or 6 a.m., where they normally go for the medication. We should know that that patient actually didn't show up for the medication. Someone in our team should be actually looking at what happened, where these clients go, how we prevent that from escalating and becoming a problem. I recall in our practice at the HIV clinic some time ago, we decided to actually generate a list of patients who were due for methadone that day, so that they needed a prescription renewal that day. And I clearly remember, and they will share with you, because some of them are here, their experience where they actually were calling around the clients. We knew where they hang out. We know where they go for a particular meal, and they were phoning around saying, John hasn't shown up. Where is John? And call John, and finally, he's just missed his doses, but we actually were able to bridge his prescription for 2-3 days while they come back, and then prevent that kind of disengagement from care. I'm not going to spend a lot of time in the model for improvement, because you probably are familiar with, and you will be talking more about that later on. Just suffice to say that in order for us to be successful, we really need to focus on what are we trying to accomplish here. We need to be very clear. We have overarching goals for you, but your teams really need to have that process, and what are you doing well and what are the areas that you could do better, and those are the areas that you need to focus. The structured learning collaborative is something that is not new, that we borrow and learn from the Institute of Healthcare Improvement from the US, and it's part of what they call breakthrough series methodology, and it's based on the idea of adult learning, bringing people like yourself together, going through that journey that I just mentioned, discovering what are the things that work, how you share them, how you learn from others, how you stop of doing things that you learn don't work, and how you let others know that those things don't work. And we go through a process, an interactive process of learning sessions and action periods, and your operations directors, some of them are here, are committed to support you to do this work. And I'm going to hold them accountable because if you tell me that they're not being supported, we need to have those conversations, because this was the success of HIV, being supported by your leadership. quality improvement also requires focus. And this is why we are focusing now on the oral therapies, because the local data that I just showed you clearly shows the gaps that are in care. And you'll see more. Dr. Cole Stanley here, who's co-leading this initiative, has done a lot of work. Ron Joe, who's probably somewhere there, has also done a lot of work in terms of our own data. You'll see more data. But today is not about data. It's just clearly there are gaps. And so we need to focus. And in addition, we also have the science that is telling us that we can do something different. What is quality improvement? Quality improvement is not an evaluation. It's not performance assessment. We're not saying how good or bad you are. It's not quality control. We're not controlling anyone here. It's not research. We're not generating new knowledge. We're using existing knowledge and moving it into practice. Quality improvement is a bottom-up approach. It's you discovering what works and how you tweak it to make it happen at your local level. And it's a system approach. We don't want to create more work for you. What we want to be sure is that you use the existing tools to drive your change, and also to ensure that you actually understand that it's a system change, but we cannot shake this whole thing. But if you shake it from the bottom and you modify the small pieces, it will have an impact at a system level. Think about those changes when you're thinking about it's not a make work for somebody else. It's how is this becomes part of your normal practice. I also want to insist in this point. So what are we trying to accomplish? I always say think big, and Dr. Montani and Mary and others really have this ability to have this huge vision. We need to start small. We need to start, and this is a call to start now. Start that small step that I suggested. Let's not wait for the perfect data or until somebody tells us that they discovered something else, because it may not happen. So the goals that we have set to this collaborative that came from a planning and a working team that was assembled I think about 2 months ago, is this. So by July 1st, 2018, and these are aspirational goals, okay? So I get it, we may not get there, but if you close your eyes and think that 30% is unacceptable, and if we could double that to 60%, we would have made a huge change. But our goals are to have 95% of those individuals who need opioid or benefit from oral opioid agonist therapy to be on therapy. We also want 95% retaining care for more than 3 months. And we want about 50% average improvement in quality of life. We will be paying attention to what our clients, the impact to this to our clients. I'm sure Francis will say, where is the family there, right? So her voice now is part of our planning team, is a part of our team, and we'll bring, as we move along, we'll bring also the client experience, those individuals who have benefit and who can tell us how they succeed. In summary, gaps in care exist. This is not about you, the provider or the client. We're not blaming anyone. This is about a system that is not designed to respond to the needs to the client. So we're still very reactive. We're not proactively seeking where they are. Don't wait for the perfect data. Take action. But I want to leave you with these thoughts, because this is what really drives me. This quote is the one that actually is in front of my desk and drives me every day. So knowing is not enough. This is when I got that report and said, okay, I know now. There is a gap in care. Knowing is not enough. We must apply. We must use that information to create change. Willing is not enough. So every time I get up in the morning and say, no, I'm willing to try this. No, it's not enough. We must do. We must change this picture. So this is how Julio and Mary and others see at the left side success. It's a straight line, right? So from here, we're going to get there. On the bottom right side, this is how we see success. The key here is how we untangle that kind of process, but we reach there, and that's what we need to focus on. I learned this at the Institute of Healthcare Improvement. I always repeat it, and people like it. Still shamelessly, look at others, what others are doing. We brought here, Dennis McCarthy will be talking to us later on, because they've done some of this work. We want to steal some of their ideas. and still shamelessly, you might want to acknowledge that's all you need to do, but use those ideas. Don't reinvent the wheel. Picasso had a saying, good artists copy, great artists steal, and we have always been shameless about stealing great ideas. That's Steve Jobs. And the other piece is share endlessly, because there's a lot of things that you do really well. And we're just chatting early in the morning here, and I learned about some of the work that's been done around pain management and how successful it is. I'm sure a lot of you don't know about that. And so how we actually expand that good practice. We're good at piloting, we're good at focusing on little things, but we're not good at scaling across our system. And we got to do this if we want to resolve that issue. Thank you very much, and I hope that you'll have really good